So, very good evening, everyone. So, we are starting our Uromet teaching session on urological infections. And today we will be discussing 5 important topics in urology on various topics of urological infections, which are frequent questions in FRC's urology examination as well. So we are honored to have 2 experts today. Dr. Mahen Kotalawala, consultant clinical microbiologist from National Hospital Colombo, and Dr. Manjula Hera, a consultant urological surgeon from National Hospital Kandy, to share their experiences with us today. Thank you very much, and thank you very much everyone for joining on time. So we will be starting with the first topic for today, the urinary tract infections, core topics, and pathophysiology, and this will be delivered by Dr. Dinendra Madhushankar. Dinendra, are you ready with the presentation?
Yes, sir. Okay, sir.
Right. Over to you, Dinendra. You can start sharing your screen.
Good evening, everyone. Today, I'd like to discuss on core topics of urinary tract infections and the pathophysiology. Before moving into topic, a bit about incidence and epidemiology. Urinary tract infections is one of the commonest bacterial infections we come across in our clinical practice, and in worldwide, the incidence is more than millions. And out of them, it costs more outpatient visits as well as emergency department admissions as well. And it is more frequent in women. And in women who are at the age of 24, at least 30% of them have 1 episode of UTI, or else in lifetime of a women, they have at least 50% chance of getting UTI. So it's a common entity. And before moving to that, few definitions to clarify. UTI is defined as inflammatory response of the urothelium, which is due to bacterial invasions, and is usually associated with bacteriuria and pyuria. And bacteria is the presence of bacteria in the urine, which is with the urine is normally free of bacteria. And this can be either asymptomatic bacteria or symptomatic bacteria, where we define asymptomatic bacteria is when the patients have a normal urinary tract symptoms and without any symptoms of UTI, but having positive samples of bacterial growth of more than 10 to the power 5 of colony counts. And when we apply this into a kind of population study, we can say it as screening bacteriuria. And when there's pus cells present in urine, we call it as pyuria, and it usually denotes infection or an inflammation of urothelium. And sometimes there can be interchangeable when the patients having bacteria but without pyuria. So it's generally indicative of bacterial colonization without infection in the urinary tract. But when there's pyuria without bacteria, so it warrants still infection is there. So we need to, and inflammation now, we need to evaluate those patients. And acute pyelonephritis is a clinical entity which includes fever, flank pain, and it accompanied by bacteria or pyuria, and it combines with the reasonable specific for an acute bacterial infections of the kidney. And chronic pyelonephritis is a condition where the kidney is scarred, shrunken, and which can be diagnosed either radiological or morphological or functional evidences, and it can be associated with sometimes UTI or not, and it can mimic some of the other conditions which can lead into scarring of the kidney, for example, in post-obstructive atrophic kidneys. Or UTI can be also described into anatomic or functional status of the urinary tract, and it can be either uncomplicated, where the patients in a healthy patient with a structurally and functionally normal urinary tract, or it can be complicated UTI, where the patients are having either structural or functional abnormality, or else sometimes the bacterial virulence factors are so high. And UTI also defined by the relationship to the other UTIs. The first or the isolated infection is the first occurrence of a UTI in a previously healthy individual. And in unresolved infection is the UTI where the patient is not responding even with antimicrobial therapy and with where the continuation of the same organism. And the recurrent infection is one other infection where the patient has previously documented and successfully treated infection. And it has two types, either reinfection or the bacterial persistence, where reinfection is a patient had a new episodes of reintroduction of bacteria into the urinary tract from the outside, or the bacterial persistence is the persistence of the bacteria from the same organism from the separate site of the urinary tract. Then we come into the pathogenesis of UTI. UTI is a kind of interaction between the uropathogens and the host, which includes few factors: the virulence factors from the uropathogen bacteria and the inoculum size, and the inadequacy of the host defense mechanisms against these uropathogens. Whenever the balance is shift towards the organism favoration, it causes a urinary tract infection. And about these routes of infection, they have described ascending route, hematogenous route, and lymphatic route, where the ascending route plays a major role. And the bowel and the perineum is a reservoir of organisms which creeps these organisms into the urethra to the bladder, and it ascends to the up to the kidneys as well. And it has special adherence to this urethral mucosa. And when they go into the bladder, they can lead into cystitis, and more than 50% of these cystitis patients can have upper tract involvement as well. And even though they have functionally normal vesico-urethral junction, they can have upper tract involvement because of these bacterial characteristics. And this prevention, this upward migration is prevented by multiple methods, and peristalsis plays a main role. And hematogenous route, again, it's not a common entity, but patients who are having significant bacteremia, especially Staph aureus bacteremia from oral route, they can have hematogenous spread. And some candid fungemia patients, and especially kidneys which are obstructed kidneys, they can have hematogenous spread. Lymphatic route, again, uncommon entity, but patients with significant bowel infections or retroperitoneal abscesses, they can have adjacent renal involvement with the bacteria, with the infection. And about these urinary pathogens, most UTIs are caused by facultative anaerobes. Usually they are from bowel flora, as we discussed. And commonest organism is E. coli, and 85% are community acquired and 50% are hospital acquired. Other than E. coli, there are another group of organisms which are Proteus, Klebsiella, and gram-positive Faecalis and Staphylococcus saprophyticus, which are community acquired. And in nosocomial infections, again, E. coli plays main role, and Klebsiella, Enterobacter, and Serratia, Pseudomonas aeruginosa, and a lot of organisms are there. And special patients who are on indwelling or intermittent catheters, Gardnerella vaginalis, Mycoplasmas, and Uroplasma plays a main role. And fastidious.
You have 5 minutes.
Fastidious organisms, anaerobics in the urinary tract, are kind of uncommon entity, but distal urethra is colonized with anaerobic organisms, and they can cause suburethral infections, and the organisms mainly this bacterial species, and sometimes Clostridium perfringens. Here's an example for this gas-forming anaerobic infection of cystitis emphysematosa, which is caused by Clostridium perfringens. And Mycobacterium TB and other non-Mycobacterium species also plays pathophysiology in UTI, and they can't be identified in routine test, and they associate with sterile pyuria as well. And chlamydia also plays a role. And bit about E. coli, which is the commonest pathogen in UTI, and it has multiple virulence factors. And these uropathogenic E. coli are classified according to this multiplex PCR methods. And out of them, majority, 70% of uropathogenic E. coli are B2 group E. coli. And they have a lot of virulence factors. They produce autotransfer proteins that may function as adhesins, toxins, proteases, and invasins. And sometimes they will cause motility mediators, and they can form this acid polysaccharide capsule, which protects them from engulfing of our immunity and make them protection. And they can have this iron acquisition systems as well, causes aerobacter. So with these mechanisms, they cause mainly invasion to our system. And bit about the pathogenesis, the main action is bacterial adherence. They adhere into the urinary tract by various methods, and they are classified either fimbrial or afimbrial methods. Uh, and these fimbria are mainly composed of either villi composed of Phylline subunits, and they are defined by their ability to mediate this hemagglutination of specific type of erythrocytes. And there are mainly three types: 1, P, and the S type. And one type we call mannose-sensitive villi, which is the commonly expressed villi, which is in both pathogenic as well as non-pathogenic E. coli. And these are mainly involved in the species who are propensity to adhere to the bladder, and it has inhibition of by the action of mannose. And then other P. pili, which is denotes the pyelonephritis pili, which has the propensity to adhere to the kidney, and it is not obliterated by mannose. And there are a few other S. pili. And bit about this catch bonds, which is another affinity by this E. coli. It goes like finger trap mechanism, where it adhere to the urothelium. And here is the diagram is showing where by this adherence, the urothelium is tightly adhered, so that this shear forces, even we can't remove the E. coli from our system. So they can tightly adhere to the urothelium. And this E. coli can cause phase variation of this villi in different sites, especially when they adhere to the bladder, it causes more villi formation. And when we go into the kidneys, they cause less villi formation. So they has villi variations or phase variations. And then in our body, as our epithelial cells also show some propensity for this E. coli adherence, especially in women who are having recurrent UTI, has propensity to this E. coli adherence. And they have found HLA-A3 type patients who are having more susceptibility for these infections. And when the organism go into the bladder, in our bladder there's a protein called uroplakeins, and they're bound to these uroplakeins, and they quickly internalize into the superficial cells, and then E. coli rapidly grow and multiply within the cells, causing intracellular bacterial community, so IBCs. And when they multiply, then they shed off and goes to another place and causes secondary IBCs. And they make a kind of biofilm so that our immunity as well as these antimicrobial agents also cannot act on them, so they can make a evasion mechanism. And how do our body prevent from them? And our body also has natural defense mechanisms in this periurethral and urethral region, which composed of normal flora, which prevents this E. coli and other pathogens proliferation. Same time, the vaginal factors like estrogen, cervical IgA, and low vaginal pH also plays a role of prevention of bacterial proliferation. And urine also kind of having inhibitory action on antimicrobial growth, and same time it shows this uromodulin or the TAM host called protein, which is derived from kidney, and which has this mannose binding site saturation. So thereby it prevents this E. coli adherence to these mannose sites. And same time it causes induced exfoliation. When the urothelium is infected with E. coli and other bacteria, it causes activation of exfoliation and get rid of the system. And when there is alteration of our host defense mechanisms, either due to obstruction, either vesicular reflux, diabetes, human immunodeficiency virus, renal tubular necrosis, these conditions will have propensity for UTIs. And especially in pregnancy, it increase propensity for UTI because it has high favorable pH, as well as there will be kind of stasis for bacterial proliferation. And especially in patients who are having spinal cord injury with high pressure bladders, having high risk of urinary tract infections. And what are the clinical manifestations when the patient develop UTI? It depends on the site of the infections. As we all know, this cystitis, pyelonephritis, they have basically a dysuria, frequency, these urinary lower tract symptoms, as well as systemic features of fever as well. And how to diagnose patients with UTI is kind of presumptive diagnosis, which is confirmed by the direct and indirect methods of analyzing of urine. And where this urine analysis, I'll skip this part where we need to collect urine, either voided or catheterized specimens. And then in the urine analysis, we can analyze the sedimented urine sample of 5 to 10 ml midstream sample, which is centrifuged up to 5 minutes of 2000 RPMs, and there we can identify a colony count of more than 10 to the power of 5 in 1 milliliter of urine is suggestive of significant bacteriuria, and it confirms our diagnosis more than 90% times. And the presence of bacteria has a sensitivity of UTI in about 40 to 70% and specificity of 85 to 95% of an ongoing UTI. And there are rapid screening methods as well, where these are nitrates in urine by a grist test or the leukocyte esterase activity can be used to get an idea about UTI as well. Confirmation of UTI is by urine cultures. There are two techniques where direct surface plating or the dip slide method we can use to culture the organisms depending on their clinical suspicions. Imaging techniques usually not mandatory in most of the instances, but where few indications are there where the patient is having potential urethral obstruction, history of calculi, potential capillary necrosis, history of GU surgeries, poor response to antimicrobial agents, diabetic patients, and other underlying kidney disease patients and neuropathic blood tests. Those patients are indicated of radiological evaluations. And about principle of antimicrobial therapy, where our therapy mainly ultimately targeted to eliminate bacterial growth from the urinary system. And this efficacy mainly depends on the antimicrobial level in the urine mainly, not in the serum, especially if it is confined to the cystitis or the lower tract infections. And the duration that this level remains above the minimal inhibitory concentration of the infective organism. And bit about antimicrobial stewardship, where we need to use rational use of antibiotic depending on our local and institutional guidelines as well as to effect on our patients. And a few about the indications of the antibiotic agents in certain patients. According to EUA, asymptomatic bacterial patients does not need to screen or to treat even, but if this patient is having following risk factors, otherwise they don't need to be treated. And in uncomplicated cystitis patients, where we can diagnose with clinical symptoms as well as urine dipstick method, can be treated with they are strongly recommending they can treat it with either fosfomycin, pivamycin, or nitrofurantoin as first-line agents, and they discouraged aminopenicillins or fluoroquinolones to treat uncomplicated cystitis. You can go through the EUA to get an idea about the antibiotics used in these conditions. And in uncomplicated pyelonephritis, where they suggest to treat with mainly of short course of fluoroquinolones as the first line treatment, and we have to if they are not responding, we can start it early with oral antibiotics. If not responding, we can go with parenteral and we can change to another antibiotics. So they suggest ciprofloxacin, levofloxacin as first line, and as oral agents, parenteral also cipro, levo, cefotaxime we can use. And in complicated UTIs, where the patient's having some underlying pathology, so there also they suggest to start with amoxicillin plus aminoglycosides, and we can use second line cephalosporins or third generation cephalosporins, and they suggest to start on cipro when there's kind of local resistance, and they discourage cipro in treating all the patients as a they discourage cipro as a kind of empirical therapy in complicated UTIs. That's all, sir. Thank you very much.
Thank you, Dinendra. I think we are running slightly short of time. May I invite Dr. Mahen Kotalawala to comment on any important matters that we have missed, or like whatever you want to stress, sir? Over to you, sir.
Shall I ask a question?
Yes, sir.
All right.
Okay.
So now it's a good presentation, and it's better if you have mentioned all your references at the bottom of the slide, so that we can see how updated your presentation and your points. And about the asymptomatic bacteriuria, that is one of the cases where we use antibiotic irrationally. So what was the indications where you need to treat for asymptomatic and bacteriuria according to
So in asymptomatic, yeah, references according to EU's current guideline. In asymptomatic bacteria, patients who are having underlying structural or functional abnormalities, or patients who are having medical diseases like diabetes uncontrolled, and patients who are in certain conditions like pregnancy, and patients with spinal cord injuries, and those groups are mainly the one who need to be treated, and other groups we can avoid our treatments.
So now this is it the guideline? Was it the what is the recommendation level for other things?
So the recommendation is, yeah, it's strongly recommended for.
Right. Okay. Right. Manjula, you have anything to ask?
Regarding, because we are counting the colony counts. So even the most of the counts, what they say is get the 10 to the power 5. But
Yes.
for the UTI, you need a lesser number. Even the lesser number of counts is significant. Yeah, even the 10 to the power 3. But
Yes.
we use the sensitivity, specificity, but increase the sensitivity. On the other hand, how you collect the sample as well. I mean, if you aspirate directly from bladder, even the lesser count would be significant. And I think even if you take directly from kidney, like nephrostomy, I think Mahin, you also agree that we might even send in a blood culture bottle, because whatever the number is significant. Mahin can't hear. You are going to tell something, Mahin? Your mic is
right. Yes. Right. So now it's like this. Now, when you take from urine, that is from meatus, the 10 to the power 5 would be the cutoff, the general cutoff that we use. But if it is clinically suggestive of urinary tract infection, even a lesser numbers can be used. In that way, we can increase the sensitivity of detection, but at the same time, it loses the specificity when you reduce the cutoff. Another thing, now, if you are taking directly from kidney or abscess or any other thing, so it's better to go for a blood culture augmentation. That is, you directly add the organism, whatever the aspirate taken from percutaneous or through stents, directly inoculated into the blood culture, so that we will be able to get a better results. And also, even a single colony is significant in that regard, not the ones that we have taken through urinary meatus or urinary urethra, right?
One more thing that, especially when these people are giving sample to private sector, ask them to give a place where they do plating and everything, because sometimes this transport will be a matter. So a lot of cross-contamination and a different organism growing and all these problems will come when the urine culture collected in somewhere else and transport.
Yeah, exactly. Now, in private sector laboratories, they are located in a central place, and they collect all samples from all collecting centers. So generally, when they transport these culture samples from the collecting center to the place where they process, it may be more than 10 hours or 12 hours or something. So the delay means you get bacteria will multiply and you will get a wrong result. So therefore, it is very important to keep the sample, get the sample to the place where they're processing within very short time, preferably within less than 4-hour time. And if there's any delay, you have to use a refrigeration or transport it in ice. Even if you're transporting it in ice, it is always better to send it before, process it before 12 hours. Otherwise, the organisms will outgrow. There are certain organisms, especially the contaminants, they will outgrow the pathogens, so that you might not be able to catch the correct organism.
Manjula sir, is there anything that you want to ask?
I mean, it's fairly good presentation. I'm happy.
Okay, then sir, we will move to the next topic. Our next, or the second topic for today is recurrent urinary tract infections. This will be delivered by Dr. Madhushankar Eknayaka. You have 15 minutes. I will remind you in with 5 minutes when you have 5 more minutes left. Over to you, Madhushankar.
Thank you, sir. I hope that my slides are visible and I'm audible.
Yeah, all good.
Good evening, everyone. I will be discuss about the recurrent urinary tract infections here. Regarding bit of introduction, the recurrent UTIs are recurrence of uncomplicated and or complicated UTIs with a frequency of at least 3 UTIs per year or 2 UTIs in the last 6 months. And when considered the recurrent UTIs, they negatively impact the patient's quality of life, leading to reduction in the quality of social, sexual, and self-esteem, and the working capacity of an individual. And initial diagnosis of a recurrent UTI should be confirmed by the with a positive urine culture. Usually, a woman with following a initial episode, 20 to 30% of women will develop recurrent UTIs. And my previous speaker also described these things, the reinfection and the relapses. So I won't repeat again the relapses and reinfections. The relapse is a symptomatic recurrent UTI with the same organism following adequate treatment. And the reinfection is previous UTI with previously isolated following treatment or second bacterial isolate. Regarding epidemiology, usually the postmenopausal woman following a 1 episode of UTI, they will have even one episode of UTI, 8 to 10% of the postmenopausal woman in a given year. And the reproductive age, the 6-month risk of second UTI following a first episode is 26%, and third UTI is 2.7. Here, the lack of estrogen causes marked changes in the vaginal microflora and recurrent UTIs in postmenopausal women. This is the pathogenesis of the recurrent UTI. I won't be UTIs. I won't be discussed here because of my previous presenter discussed. Bit of host risk factors for recurrence: presence of immunocompromised diseases, CKD, diabetes, immunosuppression, the patient with renal transplant, HIV/AIDS, and the patient's nosocomial factors, and the resistance traits and instrumentation, and other mechanical and physiological incontinence, presence of a cystocele, and the presence of a residual volume more than 50 ml of volume, and age-related associations of recurrent UTI in women. When considered young and premenopausal women, sexual intercourse, use of spermicidal agents, and new sexual partners, the patients with mother with a history of UTIs, and the history of UTI during childhood, and the patients, especially with blood groups, antigen secretory status, are more prone to get recurrent UTIs. In postmenopausal and elderly women, the history of UTI before menopause state, and the urinary incontinence patients, the patients with atrophic vaginitis due to estrogen deficiency in the postmenopausal stage, the presence of cystoceles, postvoidal urine more than 50 ml, then the blood group antigen secretory status, urinary catheterization and functional status of the patients, and the elderly institutionalized women. initial evaluation of recurrent UTIs. Most women with recurrent UTIs don't have anatomical abnormalities, so extensive investigations are not warranted in the current EUA guidelines. Here, the history, physical examination, including the pelvic ultrasound for residual volume and the urine culture as a baseline test. And the further evaluations are recommended in patients who have congenital abnormalities, the prior pelvic surgeries, and the patients with UTI confirmed with Klebsiella, Pseudomonas, or Proteus, and the patients who have history of stones, pyelonephritis, are warranted further evaluation. Also, the negative cultures with recurrent UTIs, we need to exclude bladder tumors, obstructive problems, detrusor failure, vaginal infections, genital infection, and neurological diseases. Regarding the complications of recurrent UTI, they can have acute papillary necrosis, overwhelming sepsis, and perinephric collections and abscesses. I would be discuss here about the disease management and the follow-up in four categories. They have behavioral modification, non-antimicrobial prophylaxis, antimicrobials for preventing recurrent UTIs, and the self-diagnosis and the self-treatment with antibiotics. Regarding behavioral modifications, avoidance of the risk factors, insufficient drinking, habitual and postcoital delayed urination, and the use of vaginal douching and wearing of occlusive underwear, and wiping from back to front after urination and defecation. The antimicrobial prophylaxis are the hormone replacement, immunoactive prophylaxis, and the prophylaxis with probiotics, cranberry derivatives, D-mannose, and endovesical instillation of hyaluronic acids and chondroitin sulfates. Regarding the hormonal replacement, they have suggested the topical estrogen therapy, and it is in several meta-analyses, they have showed that the superior to placebo and superior to, and it has low side effects when compared to oral estrogen also. So they have strongly recommended the hormonal replacement in recurrent UTIs in women, in mainly the postmenopausal state. And regarding the immunoactive prophylaxis, there are various immunoactive agents like OM89 is an immunomodulatory mechanism causing begins with the non-specific activation of the dendritic cells of gut-associated lymphoid tissue, and the use of heat-killed uropathogenic bacteria as vaccines, and especially the MV140, it's a sublingual whole cell inactivated bacteria, uropathogenic bacteria. These are the recent article regarding the sublingual use of ME140, prevention of the recurrent urinary tract infection. And they have concluded that it has clinical efficacy in reducing the recurrent UTIs with women suffering from this condition. Regarding the probiotics, in the current EUA guideline, they have assessed the 11 systematic reviews. They are concluded that the prophylactics with vaginal probiotics has beneficial clinical effect for the prevention of recurrent UTIs. But these are low quality data, and specifically these probiotics are probiotic species are the below mentioned one, the lactobacillus specific groups, not the all lactobacillus species. And prophylaxis with cranberry, there are heterogeneous evidence, there's mixed evidence, and those are only effective in certain population, and it's a weak recommendation in the UA current guidelines. Regarding the prophylaxis with the D-mannose, they have also the several meta-analyses, including randomized control trials. They have shown that they're effective for recurrent UTI prevention compared to placebo, with comparable efficacy to antibiotic prophylaxis. But to suggest strong, those are weak evidences, overall low, based on the overall low quality data. and the intravesical instillation of hyaluronic acid and chondroitin sulfate. Then regarding the methanamine hippurate, it's a agent converting to the in the after it is converted into the formaldehyde in the urine, and they have effective for prevention of the UTI in patient without renal tract abnormalities, and they have strongly suggest the methamine for prevention of the recurrent UTIs in women. And regarding the antibiotic prophylaxis, use of continuous low dose antimicrobial prophylaxis and post-coital prophylaxis, and the self-start antimicrobial therapy when the patient feels or patient make the diagnosis and start appropriate urinary antibiotics, usually for 3 days with quinolones. It's a strong evidence, strongly suggesting the current EUA guidelines. And the use of choice of the antibiotics, usually we suggest trimethoprim, Cotrim, or nitrofurantoin can be considered as standard regime. And breakthrough infection can be treated with low dose fluoroquinolones. And in the pregnancy, we use first generation cephalosporins as prophylaxis.
Madhushankar, you have about 5 minutes left.
Okay. And regarding the efficacy and the side effects, oral prophylactic antibiotics reduce the recurrent UTI number-wise 8-fold, and the UTI episodes per patient year is reduced by 95% during the antimicrobial prophylaxis. But interestingly, they don't modify the natural history of the recurrent UTIs or long-term effect on the baseline infection rates. And when discontinued the treatment, 60% will reinfect within 3 months, and it associated with the drug side effects also. Recurrent UTI during the pregnancy, low dose prophylactic antibiotics can be given until delivery. This is the current recommendations of EUA, and I discussed earlier. That's also my references are current EUA guideline and the Oxford textbook of surgery, urology.
Thank you, Madhushankar, for sticking to time and presenting all these things very clearly. So, Mahen sir.
Yeah. So now I just had your look at your reference regarding that vaccine, right? So the trial was done by Immunotech, isn't it?
Yes, sir. That's there are conflicts of interest. Yeah, I was to mention that.
Yeah, so that you have to when you are presenting in a forum, you have to tell about that, right? So because now you know the vaccine the issue regarding Pfizer vaccine, no? So there had been a lot of conflict of interest. Now it is emerging. So earlier they used to say that it is effective, but now we know that the company has changed the data. So therefore, when something like that, when you're, it's okay, it's totally okay now. It's MV140. It can be a good thing or a bad thing. But anyway, you have to particularly look into that, whether when somebody is recommending some sort of a vaccine or something, to make sure that conflicts are not involved, right? So again, this recurrent urinary tract infection is a nightmare, and it's very difficult to manage, and we don't know how to manage. And sometimes we tend to give prophylaxis, and we don't know how long to give prophylaxis and all these things. But anyway, with a recurrent urinary tract infection, what we have to do is, it's a complicated story with a recurrent urinary tract infection. Mostly, even if you treat them, there's a very high chance that you get relapse or a recurrence. So it's a nightmare. Manjula, what do you say?
Actually, Madhushankar asked me what are the questions I'm going to ask today. I didn't tell. So I want to ask one question. So when you talk about this, we used to give nitrofurantoin and cefalexin most of the time in Sri Lanka as prophylaxis. What is the advantage of preventing resistant form formation with this why it is so advantageous regarding resistant form formation compared to the other antibiotics?
So usually we give low doses of nitrofurantoin and cefalexin. So in the therapeutic aspect, we are not giving those, and because of that, the prevention of the resistance will be less, and resistance will be less, and we treat it with different antibiotics for the therapeutic purposes.
Yeah, but actually, what they found was it is not going up to the rectal flora, the nitrofurantoin and low dose of cefalexin, so it won't alter the gut rectal flora. That's what I have found. So, Mahen, what do you think about? Is it
actually, I have not read about that, Manjula, but I've been looking into that.
Textbook handbook actually.
All right, right.
They have mentioned that is the advantage of those two drugs.
Together, when you give it together.
Another thing regarding this using this spermicidal agent and sometimes this what is called as foam bath and things discourage patient with recurrent UTI. Any explanation, Madhushankar?
So it will alter the colonization.
Yeah. It destroys the lactobacillus flora in the vagina. So subsequently, the gut flora and come and occupy the area and that predisposed to recurrent infection in female.
And one other issue, now this recurrent urinary tract infection, you have mentioned only about the bacteria, no? So sometimes Candida can cause recurrent infections. So in that case, it is not the UTI, it is the vaginitis, Candida vaginitis that you might have to treat. Isn't it so?
Yeah. Vaginitis is must in recurrent UTI patient. You are always vaginitis. Because that's the primary focus which has end up. And one more thing is a nightmare is the patient with papillary necrosis and recurrent UTI. Because whatever antibiotic you, whatever gives to patients, the upper tract, all these bacteria with the biofilm, they well protected. Yeah, we can't remove those things. So it's a nightmare.
Another thing is recurrent recurrent UTI in pregnant women, not pregnant, childbearing age group, the sexually active age group. So even if you treat, so there's a possibility that they can get the same flora from their husband, right? So therefore, sometimes say they do this post-coital voiding. So just to flush off whatever the bacteria. I don't know how effective that is. So that had been a age-old practice from practitioners to advise the young female who are coming with recurrent urinary tract infection, the people who are sexually active, to practice this.
Another thing, Mahen, for the people who are after sexual activity, ask the lady to drink about 400 ml before go to the bed. So they have to wake up in the night, pass urine, and that you should encourage them. Even patient with recurrent UTI, so if they void at least every 3 hours, right? I mean, that is not difficult because when you wake up, when you go to your job, tea time, lunchtime, evening tea time, when you come back home, before go to the bed, and once in the midnight, 8 times you can pass without interfering in your day-to-day activity. That is, I mean, because we have to be more practical, because if you ask to drink 5 liters, they can't do their job. So they can earn. So you have to give sort of practical sort of advice regarding fluid intake and voiding. And it varies from Colombo to Kandy. You may have to drink more water when you are in Colombo. So 2 liters, 3 liters, I mean, it's very difficult to advise from different places.
Yeah, other thing is this double voiding. So that is to reduce the amount of residual volume. So, you know, when there's residual volume, there's chance that it can harbor this thing. So you can modify, pass the urine, hold it halfway and pass it rest. So to minimize the residual volume, which is one cause for recurrent recurrent urinary tract infection. So all these things are basically not antimicrobial activity or killing bacteria. It is basically the, as you very correctly mentioned, modification of the lifestyle. Because recurrent urinary tract infection is a lifestyle disease.
And sometimes it's very difficult to differentiate from a true recurrent UTI with this dysuria and this all the pelvic floor disorders. Because when you get...
Another important thing, you have to think of herpes simplex infection, right? Herpes simplex infection and asymptomatic bacteriuria operating together. So you will get symptoms of urinary tract infection, and at the same time, bacteria may be positive. So you have to think of that, and also you have to look for these ulcers and all non-bacterial causes of symptoms. I'm okay.
Yeah, I'm okay.
Madhushankar, when you ask about the questions that can be asked, usually in the exam they give you a case scenario, or like they might ask what are the points in history you would try to get from the patient, what are the points in the examination, and then what are the things you're looking for, and then what are the important investigations. Say, we don't use the dipstick much in Sri Lanka, but dipstick is a very common thing. You need to know the color change, how that's happening, and then the pathogenicity, virulence factors, and these theoretical things might be asked. So you better have an idea about what these things are, and how would you manage. I think we have discussed all these points, but you have to put them together and come up with a concise answer for the exam, right? So we have covered all these in these talks, but in the exam you have to be very concise and give all these points to the examiner in a very quick way. Okay, I think Mahen sir and Manjula sir, we have asked the questions. We can move to the next topic, no, sir? Okay.
Yeah. Next topic is GU tuberculosis, to be done by Dr. Mahendra Herath. So Mahendra, over to you. Please try to stick to your time. Otherwise, we'll lose the time for discussion.
Okay.
Yeah, okay.
Good evening, everybody. Today I'm going to discuss about genital tuberculosis, a little bit about epidemiology. In 2013, WHO estimated about 1/4 of the world population is infected with TB in its latent form, and the GU-TB occur about 90%, more than 90% in developing countries. And in the developing countries, GU tract is the second most common extrapulmonary size after lymph node tuberculosis, and it affects about 2/3 of it is affected male people, and generally it's a disease of adult, but it has been reported in children as young as 2 years of age as well. And microbiology, it is due to group of closely related atid bacilli known as Mycobacterium tuberculosis complex, and by far the most frequently isolated species in human TB is the Mycobacterium tuberculosis, followed by Mycobacterium bovis. And the development of GU disease, there are 4 main means by which GU-TB develop. The main aspect is the hematogenous spread. It's the principal route, and it may be localized or widely disseminated disease. Then there is ascending or retrograde GU-TB. This is usually occur after bladder irrigation with BCG. Then contagious from the other organ, which is very rare, but it can spread from the spine, swallow, or GI tract. Then direct inoculation, which is also very rare. This is to the external genitalia. Then the clinical features, usually those are non-specific, but symptoms correlate with the severity and the location of the disease. And about 8.4% are asymptomatic. And typical constitutional symptoms such as fever, weight loss, night sweat, malaise present only less than 20% of cases. And up to about 50% have only dysuria on presentation. And about 50% patients have storage symptoms, and about 33% have hematuria and fan plane, and about less than 10% have renal colic. This is corresponding to the passage of necrotic papillary tissue, clots or stones, and typical laboratory finding in GU-TB is sterile pyuria and hematuria. This is usually occurring more than 90% of patients. And when it comes to renal TB, it's count about 80% of the GUTB. This is highly progressive and destructive over time. So pathological findings are depending on the severity of the disease. So granuloma forms in the renal parenchyma, and they pulse, and when they caseate, form cavities with necrotic materials, which result in abscess, chronic pyelonephritis, parenchymal and papillary necrosis, as well as sinus formation. As infection advances, calcium become inflamed and calcified, resulting calcium distortion, dilatation, and stenosis. With enough disease progression, usually the kidney become non-functioning. We call it autonephrectomy, which is occur about up to 30% with GUTB. There are two types of autonephrectomy. One is casio-cavernous type, where viable tissue is replaced by granulomas. Another type is fibrotic type, where the severe scarring and calcification occur. And because of chronic inflammation, this can lead to squamous metaplasia in renal pelvis, which can cause there's a risk of squamous cell malignancy in the renal pelvis. Then ureteric TB. This is due to TB bacilli descend from the bacteria from the kidney. As bacilli pass through the ureter, granuloma can form, and infected calculi also can come and lodge in the ureter. With the inflammation, scarring and stricture forms, and this is usually occur at the VU junction, but can develop in a panureteric manner, causing panureteric strictures. These stricture leads to obstructive renal failure, and sometimes they can have reflux as well. Then bladder TB. This is usually due to descending bacilli, and usual site of the bladder TB is bladder dome, and the trigone and neck usually remain normal or unaffected. And the bladder TB can cause patchy cystitis, ulceration, causing irritative symptoms and hematuria. Again, with the chronic inflammation, bladder become contractures, and it called thimble bladder, and it forms low capacity bladder. Then epididymis, vas deferens, and testis and scrotum TB. Epididymis is the second most common site for GUTB after renal TB, which is about 10 to 50%, and in 34% it is bilateral. And with the inflammation, fibrous narrowing of lumen as well as hardening of the epididymis occurs. Once infection spread to the vas deferens, it becomes thickened and bedded in examination. The more commonly, TB epidemic extend into the testis, where it forms granuloma. Once normal testis tissue replaces granuloma and fibrosis, hard mass develop in the testis, which can mimic a tumor. Then prostate and seminal vesicle. This is due to hematogenous spread or urinary contamination, and usually occurs in about 20 to 50% of the GUTB patient. When hematogenous spread occurs, infection occurs in the periphery zone of the prostate, spare in the urethra. So those patients remain asymptomatic and result in calcified hard prostate. When the urinary contamination occurs, infection occurs around the urethra. So these patients present it as a bacterial prostatitis. The prostatic nodules of fluctuation may be palpable in the perectal examination. The TB in the seminal vesicle usually cause infertility, but may be the major presenting complaint of the GUTB. An infection is spread either from the epididymis, testis via vas deferens, or kidney, bladder, prostate via ejaculatory ducts. Then urethra and penile tuberculosis. Urethra usually appears resistant to the TB, but involve can occur in about 2 to 4% of the patient. Usually occurs with the prostatitis and associated with the fistula. And isolated urethral TB and primary urethral TB is extremely rare. Usually these lesions begin on the skin and spread to the cavernous tissues. With the inflammation and granuloma formation, it can mimic malignancy, and with the distortion of the penile, erectile dysfunction occurs. Orificial TB. There are two types of penile TB. One is orificial TB. This is rapidly necrotic form in immunocompromised patient. There's a painful ulcers occur, and it represents advanced and severe TB elsewhere. Then there's other type, papillonecrotic tuberculoid. This is again extremely rare presentation where cutaneous manifestation of TB in gland penis. These ulcers do not contain TB bacilli, and response to empirical anti-TB will confirm the diagnosis of PNT. Then diagnosis. The primary goal of diagnostic workup is the isolation of TB bacilli in the culture for ABST. In the right clinical context, tissue diagnosis relies on samples demonstrating granuloma, probable exposure, and response to empirical treatment. The culture is the gold standard for diagnosis. The first voided midstream early morning sample is the best urine sample for culture, and about 3 to 5 consecutive samples should be collected. And traditionally used culture medium is the egg-based Lowenstein-Jensen medium, but it takes about 4 to 6 weeks to produce the growth. This is as inexpensive. It is usually used in developing countries, but in developed countries, there are more expensive egg-based transparent solid media, which give culture positivity about 1 week earlier than Levin-Johnson medium. And the nucleic acid amplification test, this usually provide result in 1 to 2 days, and it aid diagnosis in patient who is having low bacillary load, in whom culture may fail to isolate the organism. But natural inhibitors in the urine lower the sensitivity of these tests. Unlike cultures, nucleic acid amplification cannot be used to monitor the response because the nucleus acids are shed from the dead organism, and test can be remain positive even with the adequate treatment. The histopathology, again helpful in diagnosis when the cultures are negative. So although mycobacteria are often not seen in the tissue, finding of caseating granuloma and appropriate clinical context can help the diagnosis. There are screening tests as well, tuberculin skin test as well, and the interferon gamma release assays. These are not going to differentiate the latent and active disease. So this is ideal for screening of tuberculosis. Then radiography. GUTBs generate very wide spectrum of imaging finding, and test of choice depend on the disease location and should be driven by the symptoms and the other clinical data. Usually X-ray KB can show calcification and calculi. And the CT-IBU, it's usually most frequently used imaging modality in the current practice, and can detect lesion about through lesion small size, about even 3 to 4 millimeter lesion. And retrograde and antegrade pyelography can be used when CT is contraindicated. And the ultrasound scan has limited role, but it is useful in children and pregnant patients, and it can use to evaluate the testis, epididymis, prostate, and seminal vesicles. Then MRI and cystoscopy, those are little beneficial in the management of tuberculosis. Then their medical treatment. Usually GUTB can be successfully treated with standard short course regimen of 6 months first-line anti-tuberculosis drugs, but in special circumstances may need extended course of treatment. And there's a controversial evidence regarding adjuvant corticosteroid for treatment of TB. Then surgical therapy. Usually about 50% or 55% of patients during their illness need surgical intervention, and usually those surgeries are done to relieve the obstruction, drain infected material, or to remove the non-functioning kidney, or to treat secondary hypertension, or to reconstruct the urinary tract. Thank you. That's my presentation.
Thank you, Mahendra. So Mahendra and Manjula, do you have any questions and comments, sir?
Right. Thank you. Another excellent presentation. And again, like the previous presentation, this is another issue, the diagnosis of urinary tract infection, TB urinary tract infection. So this is actually specimen collection, transportation is very important. And you can do, you said that PCR reports are available within 1 to 2 days. But if you do gene expert, you may be able to get the report within hours. And anyway, even with the PCR, even if you have done PCR, it is very important to send the urine for culture. And you have to select places where TB culture is done. It is not done in all the places. Even it is not done in NHSL, it is not done in NHK. So you have to send it to one of the medical faculties or Valisara to get the things done. Early morning, 3 samples, and you have to centrifuge and look for the particular organisms. And especially when you are diagnosing renal TB, you have to look for TB in other areas. As you correctly mentioned, TB, renal TB or TB urinary tract infections usually occur secondary to TB from other side due to hematogenous transmission. So that has to be looked for. Not only you are look for the urinary tract infection, but you have to look for possible focus from other side. Usually it will be lung. It will be lung. The primary site would be lung. And other thing is the importance of MAN2 test. MAN2 test, the positive result and a negative result. Whether it is correlating with extrapulmonary TB. The commonest extrapulmonary TB is renal TB, no? Renal TB and bone TB. And how you can use MAN2 in diagnosing renal TB. Other important thing that I want to raise is the role of radionuclide imaging. So that's PET and this indium and technetium scans. So especially not only renal TB, there is TB, mediastinitis, and any other places. You can get high positive results with imaging with radionuclide scans, indium, technetium, or MRIs. Not MRIs, PET, right? So that. Another thing is the histology, right? Where mostly you won't be getting a culture positivity, but you will see histology. And when you are doing histology, you have to look for the classical granuloma and caseation. And in addition to that, if you speak to the histopathologist, you can get acid-fast stain on the histology sample, right? So that also can be used to diagnose. So that's something that I want to mention. Manjula?
Is there any special medium to transport these cultures?
Special medium in the sense TB is not like other organisms. It's a fairly resistant organism. What you can do is you can take the biopsy and this thing, and you can send it in the normal ice to the laboratory. So they won't survive. They will survive. The organism will survive. And in histology, if you are sending histological sample for acid-fast staining and gene expert, make sure that you send it in a ice and not formal saline, right? Because sometimes we might have to culture, no, right? So if you send it to Valisara, they do gene expert as well as they inoculate it in normal culture media. And about the rapid culture media, there are automated culture media, just like what you grow in blood cultures. In Valisara, they have automated cultures for TB. Midget. It's called midget, right? So that can be done, and it is a liquid-based culture media, and you can get results as early as 7 days, or maybe you can get a negative result by 3 weeks. So that's the thing. Another thing that is available in Sri Lanka, but it's available in Valisara. Midget, broth-based culture media.
The problem is, I mean, if you know that all the presentations are there, then we can beforehand, before the cystoscopy, we can think of TB. But sometimes it's because we assume that it's a tumor, and we do the TURBT, and histology comes as TB. That is, I mean, something we have to think of.
Actually, TB is better, no, rather than having a tumor.
Yeah, that's true. But I mean, at the time of the resection, sometimes we may not aware about that is we are dealing with the suspected TB patient.
Oh, now you will have a big problem. That is to decontaminate the cystoscope.
That is true.
So that has to be addressed. Ne? So now if you have only one cystoscope, so if you happen to clinically suspect tumor and you see a picture similar to tuberculosis, so then you have to pay extra caution. You have to be extra caution to prepare the Manjula.
Yeah, I mean, but
Clinically, hituat, you have to do that, no? If you think of now, if you tell once after you doing scope, and if you suspect TB, and you can't process the scope as you are doing for the routine case, you have to think of a different way.
What do you recommend, sir?
Yeah, you have to do 20 minutes. You have to
20
keep
minutes in
20
parentheses.
minutes with whatever the thing that you are using. Actually, now we are facing a big problem. We don't know. Different hospitals use different reagents. It's not available. And certain things when you use, the sheet get distorted. What do you think? You had that problem, ne? In Kandy? So any Manjula is not there.
yeah, I'm here. Yeah, that's the problem. I mean, regarding instrument protection. No, what I'm telling is sometimes we don't know it is TB when we go. That can't help. I mean, only once a histology comes, only we know that it's TB.
Yeah. So it will be a retrospective, no?
Okay, sir. Then shall we move to the next topics?
Yeah.
The next topic is emphysematous pyelonephritis and xanthogranulomatous pyelonephritis will be done by Dr. Chaminda Lahakon.
Good evening, everybody. I'm Dr. Lahakon. I'm going to discuss about two different infectious diseases of the kidney. First, I will move into this emphysematous pyelonephritis. So, by definition, emphysematous pyelonephritis is a severe necrotizing type of infection which will caused by a gas forming organism will result in a tissue destruction as well as accumulation of the gas within the parenchyma of the kidney. So, this is usually considered as urological emergency because it might need surgical intervention as well. And usually this affects commonly among women, and it is says that about 6 times more common than the men, and as well as almost all patients are diabetic patients with poor diabetic control. When considering this emphysematous pyelonephritis, we should also have an idea about this emphysematous pyelitis, which is a less severe form of infection where there is gas forming organism in the urinary tract infection causing the gas accumulation only in the collecting system. So it is usually a less severe disease. So when consider the clinical presentation, those patients are mostly presented in their 4th or 5th decade, and usually they come in with acutely coming with high fever and as well as some features of septic shock, including the confusion and the features of delirium. And usually there is this classic triad mentioned, including this fever, vomiting, and the flank pain. And on further examination, generally they may show the features of septic shock, including the tachycardia and the hypotension. And if you examine, you might find this there will be this severe tenderness over the renal angle, as well as if it is a very advanced disease, you might be able to feel the crepitation over the flank. Pneumaturia are not always present, but if there is involvement of the collecting system with the collecting gas in the collecting system, the patient might experience pneumaturia as well. Then goes into the pathogenesis. The pathogenic organism most commonly is the E. coli, and apart from that, the Klebsiella proteus and the Pseudomonas may be encountered in this disease progression. And usually this E. coli in here is the most virulent type of E. coli which causing this disease, and so there will be around 50% of the time there will be bacteremia present with this case. When considering the pathophysiology of this gas formation, so usually all those patients are diabetic patients, so they are having this glycosuria. So fermentation of this glucose by the E. coli might produce the gas, and as well as there may be this impaired transportation of the gas produced by those organisms. So this again may be driven by this diabetic microangiopathy as well. When consider risk factors, yes, we all know this diabetic is the most common risk factor. Apart from that, the alcoholism and drug abuse, and as well as anatomical anomalies and the neurogenic bladder can cause this, can cause the risk factors for this disease condition. Moving to the diagnosis, basically we have to do this full blood count and the renal profile as well as creatinine profile, because those patients might present with the DIC with the development of the sepsis, and the blood and urine cultures are always necessary. For the imaging wise, first we can go for ultrasound scan and the X-ray KUB. There we can demonstrate the gas in the urine, gas in those tissues, and as well as the mainstay of diagnosis, the CT KUB. There we can see the presence of gas and the extent of the gas, and as well as there's any presence of obstructive cause. And usually about 25% of those patients having an obstruction in the upper tracts. From the CT KUB, we can differentiate this severe disease as well as a less severe disease. So usually in the severe disease, there won't be any perirenal or renal fluid, but the gas would be streaky or mottled. So if those features are there, they are having this high mortality associated about 50 to 60%. So there is a staging system which describes this pattern of involvement in this episematous pyelonephritis. So there is grade 1 to 4. So the 4 is the most severe one, whether it is a bilateral disease or a episematous pyelonephritis in the solitary kidney. Apart from those things, so there are described adverse prognostic factors which will associate with this episematous pyelonephritis. If those features are there, the mortality would be invariably high. So those include this hypoalbuminemia and septic shock at the initial presentation, as well as bacteremia, and also whether there's any indication for hemodialysis, thrombocytopenia, and polymicrobial infection. So when moving to the management either would be conservative management, minimally invasive management including the percutaneous draining or stenting, or a surgical management. When moving to the conservative management, that includes this patient most of the time they present with this septic shock, so the fluid resuscitation is a mandatory part. And apart from that, we have to choose the correct antibiotic, so that will depend on the previous culture or the local policies. In our unit, we usually practice initially with the IV choanasclave, and if it is not responding with the IV meropenem, though this guidelines mention about this ticagrelor with clavulanic acids. And if necessary, urethral catheterization and the percutaneous drainage would be helpful. And also it's very important to control the diabetes. And there are a few studies which will assess this efficacy of conservative management. So with this emerging antibiotic therapy, so they found that there is an increased overall survival with the conservative management. So it is up to about 90%. So, but in the early, that is in 1980s, the mainstay of management would be the surgery, that is emergency nephrectomy. But this is also associated with the high rate of mortality, around 40%. And this, there is one paper that was given in this Campbell-Walsh. They shows that even with this nephrectomy, there is a high rate of mortality, and than the conservative management. So that also conclude that the conservative management has superiority than the early surgery. So the surgical management will depend on several causes. If there is evidence of obstruction, yes, in that case, we have to do the either percutaneous drain or a stenting, or even if there is perinephric collection, we have to go for a guided drainage. And if it is failed, then we have to consider about open surgery, including the nephrectomy. And also we have to consider about the functional status of the kidney. If it is a non-functioning type of kidney, in that case, so invariably the nephrectomy will be indicated. And as well, if there's a failed medical management, if the patient is deteriorate after 48 hours, so in that case also we have to think about the open surgical management, including the nephrectomy. So usually this mortality of this disease is mentioned as around 90 to 43 in different case series, but recent data suggests that there's overall survival of 88% is there. When we move into the other infectious condition, that is xanthocanomatous pyelonephritis, which is an infectious granulomatous disease condition with affecting the kidney. So this is a type of chronic pyelonephritis which has this destruction of renal parenchyma with the presence of granulomas, abscess formation, and collection of lipid-laden macrophages or the foam cells. So usually gas formation is not a feature here. And this is usually occurred following obstruction of this upper tract with the stone, which will result in non-functional and abnormally large kidney, which will mimic a renal cell cancer. So with this picture, there will be this diagnostic dilemma, because macroscopically it can be confused with the renal cell cancer and also other inflammatory disease like chronic pyelonephritis and melocopacia of the kidney. And as well as if the microscopically, if we send this specimen for in the intraoperative time for the frozen section, that the histopathologist may difficult to diagnose clear cell adenocarcinoma from this xanthocanomatous pyelonephritis. So pathogen, earlier thought it's the most common pathogen would be the E. coli, but the emerging data shows that the most common pathogen is the Proteus, and as well as there are mixed anaerobes also there. When considering the pathogenesis of this xanthocanomatous pyelonephritis, the main three features are this nephrolysis, obstruction, and the infection. So this primary obstruction followed by this infection with the E. coli can lead to tissue destruction and the collection of lipid material by macrophages. Then those macrophages are distributed in the sheaths around this parenchyma and abscess and calyces, and intermix with lymphocytes, glial cells, and the plasma cell with formation of this granuloma. Apart from those features, there are other possible factors that will support this pathogenesis, include this venous occlusion, abnormal lipid metabolism, lymphatic blockage, and renal ischemia, and altered immunologic competence. So when considering this virulence of this bacteria in this pathologic processes, it's very low. So due to that reason, the spontaneous bacteremia is rarely seen in this disease process. And so by considering all those factors, this disease pathogenesis is not due to single instrumental factor. So rather it is an inadequate host inflammatory response with obstructed ischemic or necrotic kidney. When goes for the macroscopic appearance of this xanthocanomatous pyelonephritis, the kidney has dilated and there is thickened pelvis with the calculi. So pelvic wall is thickened with fibrosis. So there is a less dilatation at the pelvis level. Instead of there is a dilatation of the calyces and this disease process either involving the whole kidney, which cause a diffuse form, and or it may be a segmental or focal disease. So microscopically, there will be this central necrosis, acute inflammation with foamy macrophages with fibroblastic response at the periphery. So those patients usually present as a chronically ill patient, and if there's a patient with ongoing UTI with suspicious renal mass, then we have to consider this as a differential diagnosis, that is xanthocanomatous pyelonephritis. So also they might having this flank pain, which is a dull pain. It's not a colicky pain, and as well as fever with chills, and as well as a persistent bacteria. And for the diagnosis, we can do the urine analysis, and we can send urine culture and the full blood count and the liver function test, because liver function also altered in this process. Imaging wise, usually this ultrasound scan kidney ureter bladder will demonstrate global enlargement of the kidney, and this and Also, we can detect whether it has involved whole kidney or a focal involvement there. So CT would be the mainstay of the imaging modality. So about 50 to 80% of them would have this classic triad of unilateral renal enlargement, low high functioning kidney, and as well as obstructed renal pelvis calculi. And apart from that, CT might show that there is this dilated calyces with the water containing, and on if it is an enhanced scan, so we might able to see this cavity wall of the cavities will have contrast enhancement, and within the cavity is non-enhancing, which is suggestive, which we can use as a differentiator this from the cancer. So this classic sign, that is BFO sign, we can see on the CT on this xanthocalamitous pyelonephritis. And the management wise, so the antimicrobial therapy, they would suggest this for initially for the stabilization prior to surgery. And so there are some data suggestive that long-term antimicrobial therapy will eradicate the disease. And but surgical management would be the first line management. So if it is a non-functioning type large kidney, so we can go for a nephrectomy. If it is a focal disease, we can consider the partial nephrectomy. But the main important factor is, if we are going for a nephrectomy, we have to remove the kidney as well as peripheral surrounding this fat and the perinephric and pararenal fat, because this if we do the partial resection, this disease recurrent would be there with formation of renal peritoneous fistula. So the approach would be open or laparoscopic. So both have their own pros and cons, but imagine data shows that laparoscopic nephrectomy and versus the open surgery, there was no additional disadvantages by doing the laparoscopy. So both have indicated in the surgical management. So with that, I will conclude my presentation, and thank you.
Thank you, Dr. Chaminder. It's a nice presentation. We'll ask the experts for the comments or any questions.
Right. Can you hear me?
Yes, sir.
Right. So now emphysematous pyelonephritis, usually the blood culture is negative because the organism is in the renal tissue, right? So I think if Manjula remembers, we investigated several cases of emphysematous pyelonephritis, and we cultured the whatever the secretions came within the renal tissue, and all of them grew E. coli. It's a gram-negative organism, and so most of them were treated successfully with meropenem. And few cases, I remember Kanchana had to do bilateral nephrectomy. Manjula, there was a case.
Actually, we could be able to save without doing nephrectomy, no?
Yeah. Most cases, I think that's the early cases that what you have mentioned in your classification. The ones maybe limited to single kidney or limited to.
Another thing that by this radiological classification alone, you should not decide on treatment, because there are few patients I have seen bilateral emphysematous pyelonephritis. It extends down to the pelvis, and partly it is going to the thorax. And patient was investigated at the medical ward, and the patient went home with oral antibiotic. And she came to me after 1 month with the CT report. It's really a strange CT report, but she's okay. I mean, I think we have to look at the other hemodynamical parameters and the renal function and septic parameters when you consider about this nephrectomies, especially patient with this severe looking images. But you can't rely only on images when you're deciding the treatment. Another thing, drainage. Most of time, these patients are diabetic. There's a high chance they may have papillary necrosis which come and lodge in the ureter, maybe the reason. So I generally put a stent for them. Nephrostomy is a bit difficult sometimes when there's a lot of gas around the kidney, because very difficult to find the pelvis. So most of the time, as it is female, stenting won't be a difficult thing.
And another thing is now most of these patients with sepsis, they come to ETU. ETU, and you need to resuscitate and at the same time establish diagnosis. That will be a really challenge, because now you keep aside the management of emphysematous pyelonephritis. First, you have to resuscitate and manage the sepsis. And that warrants, that is before establishing diagnosis of emphysematous pyelonephritis, you have to treat and stabilize the patient at the ETU, because most of them are presenting with severe sepsis, septic shock. We might have to give salvage treatment. So most of the time, it's not, it is vancomycin and meropenem together to salvage the life, right? So that sort of thing might have to be done, and you will be getting the patient after stabilizing the ETU. Isn't it like that?
What is the overall picture of the patient, and stability will be the matter when the emphysematous pyelonephritis patient comes to you.
Yeah, good. Shall we move to the next one?
Next topic is venous gangrene and urosepsis. Will be done by Dr. Niranga Samarasinghe. Dr. Niranga, over to you.
So venous gangrene. So this is a potentially life-threatening form of necrotizing fasciitis involving mainly the male genitalia. It has many names. It has idiopathic gangrene of the scrotum, streptococcal scrotal gangrene, perineal phlegmon, spontaneous fulminant gangrene of the scrotum. Even though it was originally reported in the literature by Behring in 1764, 1883, the Fournier's described it markedly, and it is in the literature as the Fournier's gangrene. Initial classical description, it is characterized by an abrupt onset of rapidly fulminating genital gangrene of idiopathic origin in previously healthy young patients that resulted in gangrenous destruction of the genitalia. However, now this differs from the current description because it involves a broader age range now, including older patients, follows a more indolent course, and currently it has a less abrupt onset. And approximately 95% of the cases now we can find out the source of infection. So infection most commonly arises from this genital tract, urethra, rectal origin. This urethral obstruction associated with strictures and extravasation or instrumentation can cause the initial insult. Predisposing factors are the common one we described previously. Diabetes mellitus, local trauma, paraphimosis, periurethral extravasation of urine, perirectal or perirenal infection, and any urological surgeries like circumcision or any general surgeries involved in the region, hernia or rapid. Infecting bacteria probably pass through these anatomical layers. It can invade the Buck's fascia of the penis, spread along the Dartos fascia of the scrotum and penis, and Colles fascia of the perineum, and it can ascend upward through the Scarpus fascia of the anterior abdominal wall. So they are having this typical foul odor associated with this condition, indicating this anaerobic bacterial origin. But the cultures can be mixed cultures containing these facultative organisms like E. coli, Klebsiella, enterococci, along with anaerobes like bacteroids, Fusobacterium, Clostridium, microphilic streptococci. In clinical presentation, the history of recent perineal trauma, instrumentation, and urethral stricture associated with sexually transmitted disease as well. They can complain of pain, rectal bleeding, and histoparenal fissure as well. There can be a dermal source, which can be suggested by history of acute or chronic infections of the scrotum and association with hidradenitis suppurativa and balanitis. Examination-wise, they might start initially as a cellulitis, which is under the port of entry. Early on, the involved area is swollen with erythematous, and tenderness begins to involve the deep fascia. Pain is the most prominent feature, and fever and systemic toxicity. Swelling and the main feature is this crepitus of the scrotum, which quickly increase and markedly rapid progression. On examination, there can be these dark purple areas of necrosis, indicative of extensive gangrene. If the abdominal wall become involved in obese patient, high-risk patient like diabetes, the progress is very rapid. So they will present with these features of sepsis with gram-negative bacterial origin most of the time. So they can initially present with a very small scrotal ulcer, then they can extend rapidly, involving the anterior abdominal wall, and they might need a very marked wound debridement for their survival. When it comes to investigation, WBC, CRP, and creatinine value might be high, and they have this peculiar hypercalcemia secondary to this bacterial lipases that destroy the triglyceride in subcutaneous tissue and release free fatty acid that will chelate the calcium. In the plain X-ray, they might identify the subcutaneous air pocket due to crepitus, and ultrasound scrotum can be done to assess any viability. Most of the time, the testis is viable because it has separate blood supply. Biopsy of the base of an ulcer can be done during the wound toilet, and taking a tissue and pus culture during the wound toilet and send in for antibiotic and ABST is essential. In management wise, it's a true urological emergency that demand early recognition and aggressive treatment. So surgical debridement is a must to reduce the mortality. So clinical differentiation between necrotitis, fasciitis, and cellulitis might be a bit confusing, but there can be pain, edema, and erythema. The marked systemic toxicity out of proportion to this local finding suggests more towards this Purnius gangrene. Management-wise, the broad spectrum antibiotics like beta-lactam plus beta-lactamase inhibitors or piperacillin tazobactam, especially if Pseudomonas is suspected, then ampicillin plus sulbactam or vancomycin or carbapenem plus clindamycin or metronidazole. In the EEA 2022 guideline, they are suggesting broad spectrum penicillin, third generation cephalosporin, gentamicin, and metronidazole or clindamycin. So immediate debridement is the essential part in patient whose diagnosis is clear. So the method of management should be extensive incision, should be made until the healthy tissues are found, until healthy fascias are found, and necrotic fat and fascia should be excised and would should be left open. We can decide on a secondary procedure or secondary wound toilet depending on 20 to 48 hours, depend on the clinical response, and occludectomy is almost never required because of the separate blood supply. To prevent the contamination, we can decide on whether there's a need of suprapubic catheter or colostomy. There are evidence of the hyperbaric oxygen therapy has shown some promising reduction in the time of hospital stay, increase in wound healing, and decrease in the gangrenous spread. Later, with the help from this plastic colleague as well, we might decide on this reconstruction using myocutaneous flaps to improve the cosmetic results. So mortality, it can range from 70 to 75%, the median value is 20%. This higher mortality rate are found in patients who have high risk factors, with diabetes, old age, and immunocompromised patients. In EA 2022, they have given evidence and recommendation that immediate empirical parental antibiotic treatment should be given that covers all probable positive organisms and can penetrate inflammatory tissue. A systemic review, they have found that regarding the wound closure technique, if this defect in the scrotal area is less than 50%, we might be able to go for a secondary wound closure technique. But if the defect is more than 50%, there's high chance of usage of flaps or skin graft for the defect coverage. There are no up-to-level evidence of benefit from the usage of this negative pressure vacuum therapy in Purnius gangrene patient. So they recommend to start early treatment of Purnius gangrene with broad spectrum antibiotic on presentation, and subsequently we have to go for this culture-based antibiotic change and commence repeated surgical debridement for Purnius gangrene, especially within 24 hours of presentation. So my next topic is the management of urosepsis. The definition-wise, this is a highly changing field. The initial definition was that sepsis is a life-threatening organ dysfunction, which was caused by a dysregulated host response to infection. So this for clinical application, now we are using this sequential organ failure assessment system, SOPA score of 2 points. And for rapid identification at the bedside level, we can use the quick SOPA, Q-SOPA score. Here we are using the respiratory rate, altered level of consciousness, and systolic blood pressure. So the sepsis is more common in men than women in literature. A rate of sepsis due to this gram-positive fungal organism has increased over the time, and gram-negative bacteria remain the dominant in urosepsis. In urosepsis, high-risk patient now, this elderly patient, diabetic one, immunocompromised patient, especially who are transplant recipient, and patient recovering from the cancer or chemotherapy and who are on corticosteroids, depend on local factors such as the urinary tract calculi, obstruction in the system, congenital urogenital anomalies, urogenic bladders, and endoscopic maneuvers might increase the risk of urosepsis in patients. So this evolution of guideline is the one we should consider. In 1992, this consensus guideline, there we use this the systemic inflammatory response syndrome in the setting of the infection. But in the sepsis 3 task force proposed a bedside assessment, which is the Q-SOPA scoring. And recently they endorsement proposing the definition for sepsis and septic shock, eliminate the word severe sepsis from the classification. And now we are moving towards the SOPA score. And this one also going to be changed the sooner. And according to this sepsis 3 guideline, sepsis defined as a dysregulated immune response producing life-threatening organ dysfunction, which should be quantified by an acute increase in SOPA score 2 or more points. The septic shock definition has changed the sepsis accompanied by profound circulatory, cellular, or metabolic derangement associated with increased mortality related to the sepsis alone and clinically identified by the serum lactate level according to the definition. So here we can see how these definitions have changed. Initially, we used these terms like sepsis, severe sepsis, and septic shock. But in the newer definition, they have removed the severe sepsis part. Now we are using the nomenclature sepsis and septic shock. And the bedside diagnosis, we can use this Q-SOPA score. We are assessing the patient's hypertension, systolic blood pressure less than 100, and altered level of concentration, GCS less than 40, and the respiratory rate more than 20 tachypneic patient. If one feature is present, there's a risk of 2 to 3% mortality. But if there are more than 2 features, there's more than 10% mortality. So the SOPA criteria to assess the organ dysfunction for the respiratory system, we can use this PaO2 FiO2 ratio, which is known as the Carico index. To calculate this, we should do ABG and assess the PaO2 ratio. And for the coagulation system, we are assessing the platelet count. For the liver, bilirubin. Cardiovascular system, using the blood pressure, mean arterial pressure, and whether the need of any inotrope. And neurological, we are using the GCS system, and renal wise, we are using the creatinine as well as urine output. And score more than 2 is the significant. So the survival sepsis campaign, they have initiated this 1 hour bundle concept. So on admission, when we are thinking of the sepsis, we should get an ABG and measure the lactate level to decide on the further management. If the lactate level is more than 2, there might need a pre-assessment as well. We should obtain blood cultures before administration of antibiotic. In urosepsis setting, we should get a urine cultures as well. And we should comply of this administration of broad spectrum antibiotic, and we should consider the local hospital pattern as well on deciding on that. And we should begin rapid administration of this 30 ml per kg crystalloid for the hypotension, and need of vasopressors depend on the patient's response. So the fluid therapy is the goal-directed fluid therapy. This is restoring the adequate tissue perfusion to the fluid resuscitation. This came to a landmark study in 2001, this reverse study, which demonstrated that early aggressive fluid resuscitation in the ETU department in patients who have with septic shock, who had a marked reduction in all-cause mortality. So this either by crystalloid form or vasopressors or inotropes or blood products. So they are targeting hemodynamic endpoints using this patient CVP as well. So this term, they coined the early goal-directed fluid therapy. So this reverse trial revolutionized this care in sepsis patient and focused on fluid therapy in the early setting. Then regarding the volume resuscitation, the cutoff mark is now is as the 30 ml per kg of IV crystalloid administered within first 3 hours of treatment. So in the absence of high quality data support from specific volume recommendation, this figure 30 ml was chosen from these 3 landmark trial. One is this process trial, ARISE trial, and the PROMISE trial. In these 3, they are using this 30 ml cutoff in the control arms to assess the mortality benefit in this early goal-directed fluid therapy compared to the usual care. So volume resuscitation, after if there's no response, we should target for this mean arterial pressure of 65 mmHg. So there the inotrope should be the first line one is a norepinephrine. So regarding the data wise, this 2015 systemic review and meta-analysis found that norepinephrine was associated with the reduction in all-cause mortality, benefit relevant to the other inotropes as well. So the same study identified that there's a trend toward mortality benefit with norepinephrine related to the other inotropes. So this dopamine should be used in there when there's a patient who is having these cardiovascular risk factors and who are refractory to the hypoperfusion, suspecting low cardiac output. The vasopressin and epinephrine are recommended as second-line agents. So in the EA guideline, when we are facing suspected patient with infection, we can use the Q-SOPA as a screening tool. If there are more than 2 scores, we can assess the organ dysfunction using the SOPA score and come to the conclusion of the sepsis definition and depend on our fluid resuscitation. If the patient is not responding to our fluid quota with the need of vasopressors to maintain the mean arterial pressure more than 65 and serum lactate level more than 2, warrant that patient is in septic shock. He should manage accordingly in a dynamic process. So in 2016, they have within the usage of antibiotic. So the ideally we should give the antibiotic within 1 hour precognition of sepsis with or without shock. Ideally after blood cultures are drawn. So in a patient with septic shock, a landmark 2006 study found that administration of appropriate antimicrobial within 1 hour of documented hypertension has a significant mortality benefit. Furthermore, within the first 6 hours of recognized hypertension, if each 1 hour delay in our treatment can average with 7.6% decrease in survival of the patient. So more recently, they have a retrospective analysis of this more than 49,000 ETU management patient, which found out that each 1 hour delay in antibiotic administration from the time of hospital arrival conferred a 4% increase in hospital mortality with patient with sepsis. So in regard this blood transfusion of red blood cells recommended only in patients who have less than 7 in absence of active hemorrhage or myocardial infarction. These IV corticosteroids are not routinely recommended, only used in the septic shock, which are refractory to the adequate fluid resuscitation and vasopressors. Regarding the biochemical markers, we are using this procalcitonin. So it's diagnosing the severe generalized infection in bacterial, parasitic, and fungal with systemic manifestation. The procalcitonin levels rise. In contrast, during severe viral infection, other inflammatory reaction like severe pancreatitis, this procalcitonin level is only a moderate or no rise. Other mark is the serum lactate, which is a mark of organ dysfunction associated with serum level and cellular level homeostasis. So serum lactate should be therefore monitored during patient with severe infection. The main source, the main concept is our source control in obstruction of urinary tract. So the most frequent neurological cause of this urosepsis. So drainage of this obstructed system or abscess and considerable removal of foreign bodies such as urinary catheters or stones, there's the most important source control strategy. The condition should be managed as an absolute emergency. So depend on the obstruction and patient viability and the fitness, we can assess DJ stenting under local anesthesia or not fit patient, PCN insertion in infected obstructed system, and early wound toilet in Funes gangrene are the clinical practice we have seen. And we should consider these adjunctive measures as well in the management of urosepsis. So fluid therapy with crystalloid or albumin. If crystalloids are not adequately increasing blood pressure, we can use this placebo leg raising as well as a help. And vasopressors, we should use norepinephrine should be as the primary one, dobutamine only in myocardial dysfunction patient. The hydrocortisone should be given only fluid and vasopressors non-responses. And blood product should be given to target hemoglobin level of 7 to 9. And in case of mechanical ventilation, this should be applied to a tidal volume of 6 ml per kg and a plateau pressure less than 30 centimeter to high positive end pressure. And sedation should be given minimally because neuromuscular blocking agent should be avoided. And we should try to maintain a good glycemic control less than 180 milligram per deciliter. And we should consider DVT prophylaxis as well. And we should consider about this Israel ulcer prophylaxis in patient with risk. We should start them on proton pump inhibitors. And always the enteral nutrition should be started early within 48 hours of admission. Thank you, sir. My resources are this Campbell and EU 2022 guideline and survival sepsis guidelines.
Yeah, thank you, Neranga, for comprehensive presentation. We'll move to the experts for coming with questions.
Again, thank you very much for that detailed and good presentation. And again, nice account on sepsis. But actually speaking, now because the sepsis definition and QSOFA had been introduced to the practice in 2016, I think. And now it is going to be replaced very, very soon.
Recently.
Yes. And there's another good scoring tool, especially for bacteremic blood culture positive cases of sepsis. It's called PITS score, PITS bacteremic score, which is a very good score to identify the prognosis, short-term and long-term, 7-day and 28-day mortality. So you can refer into that. That is the one that which is coming up, which is called Pitt's bacteremic score, PITT. It's bacteremic score, and there is a shortened version like in Q so far. It's called QPIT, PITT, so that you can check on that. You can decide on prognosis of cases of bacteremia positive cases. So it gives a breakdown at 4. So if the score is more than 4, the mortality risk is very high, right? So you can try it, and it is the one that which is coming up, Cupid score, right? Manjula, anything to add? Manjula?
Did the marvelous job. I think the reason is behind him is Dr. Gunawardana's image is there. The giant of urology. Niranjan? Yeah, behind you, Dr. Gunawardana's image is there. Yeah, that may be the reason that you did that job.
Right. I have a small question from asking from you. Why did you use all capitals in your presentation?
No, sir. My laptop didn't work, so I had to use this Word laptop, sir. The font was not there. So original font was changed into.
I thought that's a particular reason. Now it's like this. The people who were trained in USA, so they tend to use a lot of capitals. That I just want to find out whether you had any connection to US. The US people were the ones that were using capitals. Huh? Right. Okay.
Another thing, I think if you put less word in the PowerPoint, that will attract people more words in the PowerPoint, because
it's crowded, no?
Yes, sir.
Very crowded slides. And so if you put the simple sentences there, and if you try to speak around that, that will be much better than that.
Especially these 10 to 15 minutes presentations, basically what you should try to limit your slides numbers, maybe 8 with point form, bulleted points. Because otherwise it will be just like a 30 minutes, 1 hour presentation, and you are trying to catch up with the time by speeding up. But when you want to discuss this 10-minute, 15 minutes presentation, you have to very closely target, and you can cut down the epidemiology part, right? So now is a 1 in 3,000 100 cases, number of cases, but straight away you jump into your presentation rather than giving the introduction, right? So what we do is we try to add some introduction, but introduction won't have any impact on your presentation. So your presentation now, if your presentation is emphysematous, Fournier's gangrene and sepsis, urosepsis, you have to straight away go into your account rather than introducing your topic, right? So everybody knows your subtopic, no? So otherwise the time will exceed. So 15 minutes is not enough to give your message. So you're planning to give a message, no? So that message is not going into the audience. So all presenters, so I saw that the introduction part. So if you want to add introduction, better to limit it to a 1 slide. Get your topic directly, right? It's very difficult, but you have to get used to them. 15 minutes presentation means 10, 12 slides. What do you think, Manjula?
Yeah, another thing, just to avoid monotonous of the presentation, if you add few, even the same slides, if you put some pictures, you can keep your audience towards you about your speech. And I just want to ask, even though the 2 centimeter margin for Fournier's gangrene, in practice, how many surgeons do that? Do they cut 2 centimeter all the time? Hello?
Yes, sir.
Yeah, I mean, even though everybody knows that you have to cut up to the very healthy tissue there. But when you cut around the perineum, especially that area where there's a lot of organs and approximation, so generally surgeons try to, there's a preponderance that they don't cut what the book says. Yeah. Try to preserve tissue, but ideally you have to cut up to the very vascular area where there's good blood supply. Because sometimes they do the wound toilet and come to us, and still there are some more necrotic tissues to remove. Okay, then good job.
Yeah.
Sorry.
Yeah. Thank you very much, DSS, Mahendra and Mandila sir, for your presence. I really appreciate being here today for as experts while having busy schedules. Thank you very much, sir, and have a good night.
Nice presentation. Good night.
Thank you, sir.